Thank you. Yeah. So I'm the bad guy here because I'm providing more accurate information. Go figure, right? Okay, so here are my disclosures. Okay, so we're talking about this progression from localized disease to polymetastatic disease. And we heard yesterday that localized disease is decided by your finger. Remember that. And oligometastatic disease and polymetastatic disease is decided by bone scans and shitty scans, not CT scans, right? So that's how it's all being defined. And what we're doing with next generation imaging is coming and talking about microscopic metastatic disease that occurs before the oligometastatic state and redefining the state. So let me just show you an example of somebody I had from the States. So this guy actually flew from Atlanta, had this scan done in Atlanta, shows, this is the same patient I showed yesterday, shows locally advanced disease, are PIRADS, 5 lesion, biopsied, and has a Gleason 9 tumor. Okay, so the standard of care is bone scans and CT scans, and there's the report. Left 9th rib and right acetabular lesions with no concordant abnormality on the CT scan. Okay, so this was called oligometastatic disease, unconfirmed, and the report actually said recommend next generation imaging with PSMA, PET, and whole body MRI. The report actually said that. And so he Googled that and tried to find a price, and that price in the United States would come at $30,000. And he Googled me, and he found that I could do this for £2,500, so 10% of the US price. So he said, okay, I'll take a first class ticket, go to London and get this done. Okay, so he comes along, and this is literally what happened, right? So here are the guidelines from the RADAR group saying that if you have a newly diagnosed prostate cancer, if conventional imaging is not confirmed, please do next generation imaging. So that's what he had done. Okay, so here's the PSMA PET and the whole body MRI. The whole body MRI is at the bottom. The CT scan is on the left, and the PSMA is the colored image just to make it easy for you. And the arrows point out where the abnormalities are. So if you look at the PSMA rotating images, you can clearly see 9 lesions. So there's the first lesion in the right pubic bone. You can see the bone scan is normal. The MRI with the downward pointing arrow, it says B800 is positive and the PSMA is positive. Okay. Here's another lesion. Here is the right acetabular lesion. You can see very positive on the PSMA, very positive on the whole body MRI, but negative on the CT scan, right? Sorry, CT scan. Okay. And I'm saying this deliberately. Oh, and here's the rib metastasis. So here's the same rib metastasis, and you can see, again, positive on the PSMA and positive on the MRI, but negative on the CT scan. And finally, this sternal bone metastasis. Now, this is the most interesting metastasis because you can see it's abnormal on the whole body MRI, but it's normal on the PSMA. So we see one more lesion on one technology that we don't see in the other technology. And we see vice versa, things happening again. So there's a number of things that we need to be thinking about. It's not just about the imaging modality, whether it's conventional or the higher sensitivity image, but also within the high sensitivity image, what technology is being deployed. And as an imager, I need to be aware of the TNM status. I need to document the number of metastases and where there are, because that definition of oligometastatic disease is dependent on the number of lesions. And of course, the temporal pattern, as we've just learned, is also important. Is the primary controlled or not? Is this, in fact, oligoprogressive disease in the castration-resistant state, or is this just hormone-sensitive? So the testosterone level is also important to me as a radiologist. So most studies so far have been focusing on CT scans and bone scans, and some CT scans, some studies have now beginning to look at fluorocholine, PET, and acetate PET. But more recently, you see this next generation imaging creep in, and we see the whole thing. We see upstaging and downstaging from M0 to M plus to M++, and it goes both ways. And that's important to remember. Let me just show you an example of a downstaging in castration resistance. So here's a typical patient, again, another American, 64-year-old, rising PSA on ADT and denosumab. And you can see his PSA is 5, and you can see something in the jaw. So immediately I'm alerted to the fact that this could be osteonecrosis of the jaw because of denosumab, 3% incidence, but in fact it turns out this is dental caries, but the PSMA is positive. So false positives occur, remember that, on PSMA and various other techniques. So for example, on the MRI scan, this is a false positive also. Okay, so just something to remember. Now you can see that there are in fact 3 deposits. So here's a right rib deposit, again, hot on the bone scan, hot on the whole body MRI, so a concordant abnormality. So this is one oligoprogressive lesion. Here's another oligoprogressive lesion, but you'll notice in this particular case, the CT scan is very positive. But the PSMA is also positive, but the PSMA is positive anterior to the CT scan abnormality. It's anterior, and it coincides with an area of abnormality. Let me just show you. So you see, it's positive here, not at the back. Can you see? It's here. So the abnormality is here, not here, on the PSMA, and it coincides to these bright dots on the diffusion sequence. So the PSMA positivity is not in the metastatic deposit you can see on the CT scan. And I think that's emphasized by this lesion. This is clearly a treated metastasis. This is dead. On the MRI, it's dead. On the CT scan, it's dead. On the PSMA, it's dead. But it is a metastatic deposit. So it is not, that deposit is, so this patient has oligoprogressive disease. So he's castration resistant. He's got 5 mets, of which only 3 are active. So oligoprogressive disease. So this is the kind of information that we can give you. But you have to remember, and we've been talking about PSMA PETs, that there are positives and negatives, false positives and false negatives that occur, both at initial staging, but also during the journey, depending on the castration's state. So for example, here's another patient. This guy came from Dubai. So this guy came along with this prostate cancer, and he's now been referred to the Royal Marsden. You can see there's a very large tumor anteriorly here. Now, if you look at the PSMA is positive on the right side, but not on the left side. This is a Gleason 9 tumor. That's interesting. And then you look at the lesion at the base, this lesion here, this is a second cancer at the base with seminal vesicle invasion. PSMA, negative. So the same patient, 2 different tumors, same Gleason scores. One is PSMA positive, one is negative. This is a problem, right? And if you look at this abnormal lymph node here, left internal iliac, positive on the MRI, negative on the PSMA. This is a problem. Okay, so you can see how next generation imaging technologies are completely classifying your patients, not only between different patients, but within the same patient, different lesions. So this is the complexity that I am now creating for you. Okay, is this important? Is this important? Clearly, there's polyclonal evolution going on, but is this important? And the answer appears to be, it probably is, particularly in the castration-resistant state. So here, for example, is patient selection by FDGPET, which is always on the left, FDGPET, and PSMA, which is here. So here you can see in this patient, FDGPET is positive here, but negative on the PSMA, in the liver, for example. Here you can see they are concordant. Now, if you look at concordance and discordance between, in this particular instance, FDG versus PSMA, you'll see their survivals are completely different. Their survivals are different. So in other words, if you get discordance between in this particular instance, FDG PET and PSMA PET, if there's a discordance, these patients do worse. So it looks as though in the castration-resistant state that what we are saying is actually quite important from a patient perspective and how they will do. At least that we know for sure. The other important thing to remember is that even within the PET scanning, there are different traces. So for example, if you were to compare PSMA PET with fluciclovine PET, you'll see that the detection rate for the same PSA is different, right? So for example, if you take PSA levels less than between 0.2 and 0.5, the PSMA PET will be positive in 45% of cases, but only in 22% of cases will it be positive for cyclovine PET, okay? This is a problem. Not only that, it's on a per patient basis. If you looked at organ by organ, you see the same issue. So if you do an organ by organ, so let's say lymph node metastases, fluciclovine versus PSMA in the same patient. So different traces will perform differently in different patients, at different PSA levels, and in different organs. Confused? Yeah, I am. But that's what the data is showing. So here's an example of a lymph node that's PSMA positive here, but fluciclovine negative on the left-hand side. This is a problem. Okay, so what are the take-home points? One of the problems is you guys can't decide on what the definition of oligometastatic disease is, right? If you can't decide, how am I supposed to give you clarity? This is an issue, right? What I can say is what you're doing at the moment with the conventional imaging is wrong, because we are showing you more disease than there actually is, okay? Next generation imaging is shrinking this oligometastatic state, defined by bone scans and CT scans. The question is, does it really exist if you use super-sensitive imaging? And that population is going to get smaller and smaller, and if you are developing an indication for that, that indication may disappear, right? So think about getting paid for this, right? Now, the question is, will next generation imaging affect the management of oligometastatic disease and oligoprogressive disease? The answer is, I don't know. I don't know because you haven't decided. And I can't help you until you decide about things like the number of lesions, where they're located, what treatment modalities you should have. Only then can I begin to help you. Thank you very much.